Cochran. I'm one of the cardiology fellows.
So those of you that are online, Matt's kind of over to the side, so sorry.
Where they stand usually?
Well, they usually stand here, but if you guys all want to, if anybody can't hear us, just let us know. But Matt's got some slides that he's going to show, which you should be able to, he shared with the screen. If anybody's having a problem with that, let us know.
So I want to keep this, kind of informal. So if you have any questions, please stop, ask me questions. We can make it interactive if you want to. But I'm really thankful for the opportunity to talk tonight. And so I was asked to talk about cholesterol. So that's what the talk's going to be about tonight. Okay. So this first slide I have is a schematic. And you can see on one side, you have a completely normal heart artery, so coronary artery. And then, let me minimize this so we can see it better. And then on the other end, you have completely obstructed disease, meaning that the blood flow doesn't get through the artery. And when that happens, you have a heart attack. And so that's what we want to avoid. And you can see that there's many steps that happen between normal to obstructive. And I don't really want to go into the basic science of that, but it's a lot of complex biochemistry. But the point is that it takes time, and it's a process that occurs over time. And each step of the way, we have an opportunity to intervene, and we want to prevent that progression from happening. So when you see this, you might think that it only happens to people later in life, or people who are very elderly or very sick. And this next slide I wanted to show you says that that's not the case, actually. And so I'll tell you where we got this data from, but you can see in the bottom that this is age groups based on decades of life. So teenagers, people in their 20s, people in their 30s, people in their 40s, people in their 50s. And it's looking to see what percent of people in those decades of life actually have some sort of atherosclerosis, so plaque buildup in their heart arteries. You can see even people in their teenage years, 1 in 5, depends on what threshold you use. This is very small amounts, 0.3 millimeters, so very, very tiny. But if you're using thresholds that are that small, even in your teenage years, you start to have some sort of development of atherosclerosis. And the way we got this information was actually from heart transplant patients. And so, as you guys probably know, that heart transplant patients usually come from healthy people who are organ donors. They're selfless enough to be organ donors, and they have some catastrophic event like a motorcycle accident or whatnot, and those hearts are donated to people who need hearts. And so what they did is, in these young, healthy hearts that were transplanted, they looked in the coronary arteries to see what percent of those patients had any sort of atherosclerosis. And that's where they saw that even in teenagers, 1 in 5 had some form of atherosclerosis building. And so what we're going to be focusing on a lot tonight is LDL. And whenever you see your cardiologist or your the provider in your heart team, I'm sure they spend a lot of time focusing on LDL. And that's because if you're thinking of it very simply, LDL leads to atherosclerosis. And again, I don't want to focus so much on the basic science, the biochemistry, but just to simplify it, LDL stands for low density lipoprotein. And the size of LDL is perfect enough that it can go in and out of that cell membrane. And so the very top part is the bloodstream, the bottom part is actually the endothelial wall. And so LDL has an easy time going in and out of that cell membrane. And so when it goes into the endothelium, it creates this cascade of events. First thing that happens is that LDL molecule gets oxidized. And when that happens, the body has this inflammatory response because it senses that it's not supposed to be there. When that happens, it eventually starts to build foam cells and macrophages, and it just gets bigger and bigger and bigger. And that's how plaque buildup occurs in your coronary arteries. And the reason why LDL is so important is because of the size of the molecule itself. And so when we think of LDL, it's really a risk continuum. And so on one end of the risk continuum, you have someone who is completely asymptomatic. They're just living their life and they have no idea that they're building up plaque in their coronary arteries. And one of the ways that this has become more prevalent is the invention of coronary artery calcium scores. And so a lot of people nowadays have had one. And what it does is it looks at a CT scan of your heart. And we make it easy by coloring the calcifications in the heart arteries. And so we have tools that can really identify calcium. And so with these CAC scores, the coronary artery calcium scores, you get a number, and that number helps you know how much you have and what percentile you are in based on people your same age. But for in this patient who has never had any heart issues, has never had any symptoms, this is all primary prevention. We're trying to prevent a heart attack from happening. And so that's one side of the continuum. And it goes all the way to the opposite side, where someone's had many, many atherosclerotic events. And so maybe they've had a stroke, which you can see with the asterisk sign in their brain. Maybe they've had a heart attack. Maybe they've had trouble with blood flow in their legs. And so I think we can all agree that if someone has had artery events occurring in multiple parts of their body, that we do want to be really aggressive. But I would argue that even we should focus as much on primary prevention as we should as secondary prevention. And so it's really a continuum, and that's why this is so nuanced between you and your cardiologist, so you can achieve your LDL goals. Because this is what we want to prevent in the long run. So this is it's an angiogram, and so this is actually I got this off Google, so it's no HIPAA or no patients, that I'm taking care of, but this is one of the main heart arteries. And so you can see that this is what's supplying the blood flow to the muscle, the heart muscle. And you can see right here that the blood flow is very limited. It's really just like the size of a hair. And so you can imagine if that any plaque were to build up right there, flow would no longer happen to this whole part of the artery. And when that happens, that's when a heart attack happens. And the heart muscle is a muscle just like your bicep that needs constant energy, constant oxygen. And so if you lose blood flow to that, the muscle unfortunately dies, and that's what causes the pain of a heart attack. And so the whole point is to prevent events from happening. So I get a lot of this information from the National Lipid Association. It's one of the leaders in guidelines for how we treat cholesterol levels. I actually was able to go to one of their conferences in Scottsdale, Arizona in October, and I learned a lot of cutting edge technology and new guidelines that will be released soon. But this organization, its premise is to enhance the science and practice of lipidology and promote optimal cardiometabolic health. And so they have a few tools that we use, a few steps that we can do to help make this problem better and to help prevent coronary events from happening. And so the most step number one, and I would argue maybe the most important, is screening. So a lot of people don't know that they are at risk for coronary disease until an event happens. They're living their life, they think that they're healthy and they feel good and it's silent, but over time they've had high LDL levels, and that's caused plaque to build up in their coronary arteries, and they might not even know. And so the National Lipid Association argues for each individual getting screened at least 3 times. One when they're a child, 9 to 11, because there are inherited disorders where people can have high LDL levels. And if you're subjected to that high LDL level from the time you're 9 years old, the likelihood of you having some sort of coronary disease event is very high. They also recommend that you get screened after you go through puberty, because puberty can really affect your cholesterol levels. And then you need to be screened at least once in your adult life after you turn 21. And then people who have certain risk factors, if they have high blood pressure, if they have stroke, they have a family history, they need to be screened at more frequent intervals. And then I think for maybe people in this group, people who are on medicines to help lower lipid levels, it's important to get annual screenings. And so, we don't want to just put you on a medicine and not know what your cholesterol panel is doing because, we want to make sure we're achieving our goals. And so if someone's on a statin or Zetia or PCSK9 inhibitor or whatever agent you're using to lower cholesterol, it's really important to be screened at least once a year. So I found this to be pretty interesting as well. And so this is the percentiles of LDL out in the public of untreated individuals. And so you can see that the 50th percentile, the LDL level is 112. Um, I don't think that meant that much to me until I was a cardiologist, but now that I see these numbers all the time, it's kind of startling that over half the population is walking around with LDL levels above 112, because those are pretty high. We'll get into the specific goals we have for specific populations, but almost everyone needs to be below 100. And so the point is that a lot of people don't even know what their cholesterol levels are until an event happens. Yeah.
If you're a child and your LDL is, say, 104, and you're an adult and your level is 104,
Yeah.
it's the same? No, it's got to be different.
So
in what respect?
Yeah, that's a really good question. So the strategy that we're moving more towards is that lower the better for a longer period of time is better. So we'll get to this later on, but I'd argue you need to be more aggressive in the child than the adult because they're going to be subjected to that LDL level for the next 80 years, 90 years. I'm not saying that necessarily has to be medication therapy, but really working on lifestyle modifications if you can, watching diet, making sure they're exercising, making sure that they're not overweight. But it's important to be aggressive even in children because the longer you're subjected to that high LDL level, the more plaque buildup there will be over time. It's a really good question. So the next step that the NLA proposes is assessing risk. And so this is a very busy slide. And so I broke it down into several parts so we could really spend a lot of time focusing on this. So there are a few thresholds we have, and with each threshold, we have different LDL goals. So this part right here is very high risk individuals. And for very high risk individuals, we want our LDL to be less than 55, okay? And, I don't think that there should be any shame or embarrassment or whatever emotion to be labeled very high risk. It's more just, we just want to know that we need to be more aggressive with LDL lowering because we want to prevent more disease from happening. But a step above that is more of requiring immediate action. So if you have an LDL over 190, that's very, very, very high. And usually, not always, usually if you get to an LDL level of over 190, that means that you more often than not have some sort of genetic disease, genetic disorder. And not always, but oftentimes, the most common one is called FH, which stands for familial hypercholesterolemia. And this is a genetic disease that affects the LDL receptor in our body. People who have that disease have less of those receptors, and that causes the LDL to go very, very, very high. And so you start thinking about this when you see someone in their 30s or 20s who has a heart attack. That's not so common to have a heart attack in your 20s or 30s. And so, it's very important to be screening for this whenever you have people who are young who get disease. And yes, you'll be more aggressive with that individual, but you'll also be more aggressive with their family members too. And so you'll screen their family members and, they'll become aware of that and you can lower their cholesterol levels and hopefully prevent disease from happening. And so if you're someone who has FH, most of the times you see a lipid specialist. So you see someone like Dr. Davidson, who was the lipid specialist here at Endeavor. And so he is very good at being strategic about combining multiple agents to get the LDL to a certain target. So now going back to very high risk individuals. So the way that you can be classified as very high risk is if you've had two major events or one major and two high risk conditions. So two of these or one of these and two of these. And so the major events is if you've had some sort of acute coronary syndrome, which is a heart attack in the past 12 months. So that would be 1 point. If you've had a heart attack in the past, more than a year ago, that's a point. If you've had a stroke, or if you've had peripheral arterial disease, which is where your limbs aren't getting enough blood flow. I think there's a chat. Oh, the name of the lipid doctor is Dr. Davidson.
Dr. Naaman also is a lipid specialist. Dr. Davidson's going to go into concierge,
Yeah.
so he's probably not going to be doing as much lipid specialty, but yeah, we can get you guys the contact information if you want to know, have more information or want to see a specific cardiologist.
And I think that they're in the process of hiring someone else. I just don't know who or that information yet.
Yeah, usually you will actually get referred from your cardiologist to then a lipid specialist. So always starting with your cardiologist or your primary care doctor, you think is a good idea, and they can order the blood test to check the cholesterol.
So, for instance, for FH, which is the very top part, there's specific genetic testing you can get done. It's through a genetic panel called Mended, and it tests to see if you have those gene receptor mutations. And so any cardiologist can order that. But if it comes back positive, that's when usually you end up seeing a lipidologist, just because you have to be, it's very nuanced about strategy to get your LDL low enough with the available tools we have. But going from the more genetic disease to very high risk individuals. So it's just very important that you and your cardiologist work knowing if you're a very high risk individual. And I don't know everyone here in the room, but I know that this is focused on cardiac patients. So I don't know, some people might be very high risk. And so if so, your goal would be your LDL getting less than 55. And so this is a change over time, because used to the Europeans were more aggressive. The Europeans for the past few years have had less than 55. The American Heart Association was a little bit more lenient. It's at less than 70. But we're moving to a more unified approach that we really want very high risk individuals to be LDL less than 55.
So don't smoke after you turn 65 either, because that automatically puts you in that high risk group.
Oh yeah. So yeah. So all these things we don't. Yeah. So smoking very very bad. So you can see age over 65, having diabetes, hypertension, not being able to get your LDL less than 100 despite being on a high into maximally tolerated statin and Zetia, having stents placed, having bypass surgery, having kidney disease, having heart failure. All those things are high risk conditions. So the next group is high risk individuals. And so that's someone who just has one or more of the following. If you have diabetes by itself, you're high risk, so you want your LDL less than 70. If you've had a CAC score, a coronary artery calcium score, that's over 100 or over 75 percentile of your age, for your age and sex, any of these events, we want to get your LDL less than 70. And then, I kind of alluded to the fact that over half of people have LDLs over 100. Anyone, we want less than 100 LDL. So optimal LDL for healthy adults. I'm me, I want my LDL less than 100. So that's what we should shoot for everyone. And so, you might ask, is there a low? Is there too low that it's unhealthy? And the answer is not that we've seen. And so there are so first, most infants, healthy infants, are born, and when they're born, they've checked LDL levels in brand new born infants, and usually their levels are 30 to 70, so as low as 30. And obviously, all of us were infants at one point, and we were fine then. And so it's clearly healthy in infants. And then there are a few genetic diseases where the LDL is mutated. And so people have zero LDL. And those people don't have memory problems. They don't have cognitive problems. Some people worry about cholesterol and brain functioning. But we've seen in people who have no LDL that they are not, they don't have any brain malfunction from that. So we really think that there's not a low level that's unhealthy. So lower is better is really what we're going towards. And so I think another part that sometimes gets overlooked is diet and lifestyle. I think that for any cardiac patient and really anyone, that should be the foundation of treatment. And so really focusing on diet and focusing on lifestyle. Lifestyle in particular is exercise. And for cardiac patients, we really shoot for 150 minutes of exercise a week. So that's 30 minutes, 5 days a week, if we're able to. And that's the number that we should all try to shoot for. I know it can be hard, but any is better than none. So if you can't get to 150 minutes, any amount of minutes is better than zero amount of minutes. And then I didn't want to make this a diet talk, but really it's focusing on vegetables, particularly colorful vegetables. So when you make your dinner or make your lunch, really trying to get all the colors of vegetables. So onions, greens, broccoli, carrots, try to really get all the colors. And then minimizing the amount of processed foods, processed and unfortunately red meat foods, even though red meat foods taste good sometimes. But and so that's pretty much the guiding theme. But I didn't want to make it a diet talk, but that's some advice.
Everything in moderation. That's what I tell everybody. Everything in moderation.
So then we get to some pharmacotherapy options for high cholesterol levels. And so I didn't know how scientific I want to make this talk. So I have a few randomized controlled trials just to try to convince you that how I've been convinced why statins and why LDL is really the driving force of minimizing disease. So the first pharmacotherapy class we have is statins. And so you can see that statins are classified into low intensity, moderate intensity, and high intensity statins. And so each level of statins has an anticipated LDL reduction. And so you can see if you're on a high intensity statin, you would expect your LDL level to go down by 50% or 50% or more. If you're on a moderate intensity, 30 to 50%, low intensity, less than 30%. And so there are more statins that are just in this chart, but if you take a statin, you're on some strength of statin, and that's the anticipated LDL reduction you should have.
So cravastatin is Pravachol, and atorvastatin is Lipitor, and rosuvastatin is Crestor. So if you're on those, that's what the generic name is of those medications in that graph.
And so statins are one of the most studied class of medications. They've been around forever, and they've been studied over and over and over again. And so I chose three. That's all the number four. I chose 3 studies just to highlight data for statins. And so the first one is called the 4S score, which stands for the Scandinavian Simvastatin Survival Study. So it has 4 S's, and that's how you got the name 4S. And so what they did, just break this down a little bit more. So double blind trial means that the person receiving the medication and the person giving the medication, so the doctor and the patient, They don't know who's getting what. So double blinded. The reason why we do that is to help avoid bias, because you can imagine that if you're giving a patient a drug that you think works, you might be a little bit more, you might treat them differently. And so you want to be double blinded, so you have no idea. And so this was in the 80s, many years ago, but this is like one of the first statin trials. But they took over 4,000 patients, 35 to 70 years old, with a prior heart attack or a prior angina pectoris, having chest pain from coronary blockages. And they had to have a cholesterol level within 212 to 309. And what they did is they randomized the patients to getting a statin, simvastatin 20, or getting nothing. And then if the people who got the statin, if their cholesterol was still high, they increased the strength of the statin. And so the primary endpoint, so the point of the study was to look to see if this had any impact on all-cause mortality. So any reason why someone would unfortunately pass away. So that was the endpoint. They looked to see if people getting the medication, people not getting the medication, if there was any change in mortality. And so you can see, so this is some research numbers, but you can see that the simvastatin's in the blue, and then the placebo, the nothing drug, is in the gray. And you can see separation occur, around 1 to 2 years. But what's more impressive and remarkable to me is this very bottom number, which says NNT, and that means number needed to treat. So that means how many people need to take simvastatin to save one person, and it's 25. So you can imagine that if you take 25 people with a prior heart attack and give them a statin, you're going to end up saving one. It only takes 25 people to save one life, which is a very low number when it comes to medications, just in general. And so you can see also a few more key endpoints. It wasn't the point of the trial, but they also looked at this, and it's the mortality from heart disease, and it's very far to the left, meaning that the simvastatin made that mortality go down a lot. And so you can kind of see in all the categories that simvastatin did better than placebo. Everything's shifted over to the left. And so this is one of the first studies. Like, what's going on here? This is kind of remarkable data. And so, I won't go as in depth through all of these, but the point is that there's been many studies. So the next one is called the Wascops trial, and this stood for West of Scotland Coronary Prevention Study, and it's very similar. They did, instead of simvastatin, they used pravastatin. There's a little bit more amount of people, it was 6,500 patients, and so they were randomized to get pravastatin or placebo, and the endpoint for that was another heart attack or dying from heart disease. And so you can see that the number needed to treat in this study was 45. And so this, I don't know how much you want to get into it. The top number means relative risk reduction. So that means that if I took pravastatin, my risk compared to someone not taking pravastatin it makes me 31% less likely to have a heart attack. So these are very impressive numbers. We don't have many classes of medications other than the GLP-1 agonists, now SGLT2 inhibitors that are coming out that have this sort of data behind it.
They started with a lower total cholesterol number in this study too, in the first one.
Yeah.
So it's, so to speak, healthier people.
Yeah, for sure. And so and then the reason why I chose this one was because it's actually comparing two statins to each other. So one group received pravastatin, a moderate intensity statin, and then a atorvastatin 80, which is a high intensity statin. Moderate intensity statin. I don't use pravastatin much, but the point is that one class of statins is much higher than the other class. And they were wondering if we use higher strengths of statin, if that would cause a change in outcomes, and it also did. And so that's what eventually pointed us to that the effect of statin therapy is proportional to the absolute LDL reduction. And so what this is this is a meta-analysis of many trials. So, I just showed you three, but there are 20, 30 studies of statins. And so what they did, so they took 27 studies and they combined them all together. And in order to get into this inclusion, you had to have at least 2,000 patients in the study. So it had to be a relatively large study. And it had to be a randomized controlled trial, meaning that double blinded, no one knows what you're getting, and it had to be longer than 2 years. And so in total, there was about 170,000 patients in it. And it was a very linear relationship. So as LDL went down, events went down as well. And so this is more of a scientific number. So this is 1 millimole per liter reduction in LDL. What we're used to is 30 points. So if you have 200 LDL of 150, you go to 120, you have a 22% reduction of a major venous events. So every 30 points you lower, it's a 22% reduction. So the point is that this is how we get the LDL theory and why we want LDL to be low.
Now I'm gonna make it more personal.
Please.
I take in atorvastatin.
Yeah.
Prior to having my double bypass and heart failure, my dosage was 40 milligrams per day. After the events and surgery, it's 80. Why the difference now?
Why the difference now? I'm not entirely sure what was happening before the event, but I know now that you've had bypass surgery, you're would probably be the very high risk category. So you want your LDL to be less than 55. And so I imagine that when you sort of size 40, your LDL is probably above 55. I'm not sure, and so I imagine they were trying to get you to goal, and that's why they doubled the atorvastatin.
And from the previous study where they were comparing how much of a diminishment in the LDL was between the dosing, so the higher dose was reducing it more, because we know that once you've had an initial coronary event, your risk of having a second coronary event, is increased. The goal is you always have coronary disease, but the goal is that you don't have another heart attack, that you don't have another blocking or narrowing.
Yeah, and because those bypass grafts can also get disease in them too, so we want to keep those bypass grafts nice and open, so cholesterol builds up in them just like your native coronary arteries.
I sometimes joke around and I say, if one pill works so well, why not take two? And the dosage that we're talking about, if 80 is so much more effective, why not start with 80?
They are now. They actually are starting at higher doses with people who have those high risk types of things. You're over the age of 65, you have diabetes, you have hypertension, all of those things.
These numbers have changed. So we used to be not nearly as aggressive. Like we used to say less than 150 is fine. We used to have very high acceptable numbers. And I think that just over time, we've realized that we want those numbers to be low. And so these numbers are, brand new. We're matching with Europeans now, but it used to be much higher. And so
even within the last couple of years.
So now moving on, I did not realize I was speaking so long, but now so there's other classes of medications as well that help lower cholesterol, LDL numbers. And so, I would say just the style of practice here at Endeavor, the next agent we usually go to is ezetimibe or Zetia, just because it's so well tolerated. And usually we're close to where we want to be with the statin, but we just need a little extra thump to get us over the edge. And so you can see that if you were to add Zetia, you would expect to get a 15 to 25% reduction in your LDL. But, for whatever reason, this is why it's so important to have a good relationship with your cardiologist because there's nuance to this. Some people can't be on a statin because of side effects. Some people can't be, for whatever reason, you can't be on certain classes of medications. And so you can see that there's other tools in our toolbox we have too. And so some of the agents that are getting the most press right now are the PCSK9 inhibitors. And that's because you can see that this amount of reduction is really high, So you can see it goes anywhere from 47 to 60%. And so, those are they're just great at lowering LDL levels. And so,
And it's not a pill you have to take every day. It's a shot that you do every 2 weeks.
Yeah.
Which some people really like. Me, I don't want a shot every 2 weeks, but.
Yeah. And so I just wanted to quickly show you that we talk about these agents, but we also have data that supports that. So this is the study that showed that Zetia, in combination with a statin, improved outcomes. Because we can say, oh, take Zetia, it lowers your LDL by 25%, but I want to prove that the Zetia itself, in addition to statin, lowers events because the point of taking these medicines is to prevent further heart attacks or further blockages. And so this is a combination of simvastatin and Zetia, and rates were reduced with a combination of the two with additional LDL lowering. This is one of the studies that got PCSK9 inhibitors approved by the FDA, because it also showed that events were reduced in patients with PCSK9 inhibitors. And so the primary endpoint for this was cardiovascular death, MI, stroke, or having to go to the cath lab to get more stents. I'm rushing this a little bit because this is just like some of the research studies, but I just want to show that there's data that supports using these agents.
And there's a wide age range there. It's 40 to 85 for this study, which is a huge number of people, in a variety of different, parts of their life. So it really is helpful, starting earlier, but it's also helpful and safe starting later in life.
Oh, yeah.
So,
yeah, for sure. And this is on optimal statin therapy. So this is someone on the highest tolerated dose of statin. They're adding the PCSK9 inhibitor to that statin. So the NLA, the National Lipid Association, has this philosophy, which is lower is better, and lower for longer is even better. So you want low levels for as long as you possibly can.
And there's no such thing as too low.
I got an email with some questions that some people had. So I wanted to, I'm not sure if anyone in the room sent these questions in. So I just wanted to, and honestly, I learned some by looking into these questions. And so one of the questions that was asked was CRISPR technology and gene editing tool. So this is, very cutting edge. So this is something called CRISPR, which is clustered, regularly interspaced, short palindromic repeats, which is basically an infusion you get that goes to the liver and gene modifies your LDL. So it's a one-time infusion you receive once, and it's forever changed your genetic profile of LDL creation. So as you can imagine, this is not we don't do this routinely. And so at the scientific sessions in New Orleans, which was 2 weekends ago, they published this paper, which is first in human trial of this gene editing therapy. And it showed that the study had 15 patients in it. Phase 1, so it's like very early. So there's phase 1, phase 2, phase 3, and it takes years for these trials to show efficacy and show safety. So I don't want to, the point is that this is just very, very early. And so it showed that this one-time gene editing therapy safely lowered LDL and triglycerides in patients with difficult to treat lipid disorders. It was conducted over the course of a year in Australia, New Zealand, and the UK. And so it's a one-time infusion, and it reduced both LDL and triglycerides by nearly 50%, which was detected within 60 days. And so I don't have much more to say other than just this article that was shown, because who knows what's going to happen. But it just concluded phase one. I think that most people are very excited by these results, but they still have to undergo a lot more testing. So phase two is when you really scale up to more people, and then so there's just a lot more involved. But it was a really good question, and this is very almost futuristic type individualized medicine. Another thing is that PCSK9s up until this point have been all injectables, and so there are actual oral versions that are coming out. And so remember, the PCSK9 inhibitors are the classes that reduce by 50 to 60, 70% of LDL. And so we saw that enlicitide was safe and efficacious, just like the injectables were. And so this is very exciting because I think that this is going to open this class of medications to a lot more people, because a lot more people will be more comfortable with taking a pill version versus the injectable version. And so it also had very high levels of LDL lowering. It was like 60% or so.
And it seems like, I don't know, have any of you guys done the shots? Okay, closer or happen. So it seems like the people that have done those shots, every 2-week shots, there's not really any side effects short of getting shot every 2 weeks, so they've had some really good results with it. It's tolerable. It doesn't make people sick. Sometimes people get muscle aches and things on statins or some GI issues with the Zetia, but I haven't had any patients that I have seen that have done the shots that have had issues with it. Just, some soreness, but again, in that hassle of going and getting a shot, or they send you a shot, and you have to remember to take it. A lot of people forget.
Yeah.
Yourself.
I think a lot of people are just scared to inject themselves.
Yeah.
And then another question we got was was regarding NIH research cuts and how that might impact this landscape. And so I was just highlighting one thing that the NIH found in December of 2024, so almost not even a year ago. But really, they were able to, within this past year, to completely map out what the LDL molecule looks like itself. Because up to this point, we didn't really know exactly what it looked like. And so this was just a study that really mapped it out and showed exactly what the receptor looks like and how the interaction occurs when it goes into the arterial wall, which was pretty neat. But I think the question also was how that might impact the future. I hope that we get more funding for research. And then another question was probiotics and prebiotics and LDL levels. And so I really spent a lot of time looking into this. I could not find any good articles that showed a huge reduction in LDL with pro and prebiotics. But this is one article I did find. And so what it showed was that there was modest reduction in LDL. So people who chose to only do probiotics, their initial LDL was 120. And then after 4 weeks, it was down to 113. So it didn't make it worse, but it made it slightly better. But that's nowhere near our goal. So I don't think, so obviously this shows that probiotics by itself won't get us where we need to go. But I don't think it would hurt if someone were to try it. Well, I did not know this can take 45 minutes, but
no, it's been great. It was a lot.
Yeah. Does anyone have any questions?
Yeah, I do.
Oh, yes.
Can you hear me?
Yes, let me, I can hear you for sure.
Okay, well, first of all, this first 30 seconds will sound a little bit like a commercial, only because I had triple bypass 9 years ago. Dr. Jonathan Summers did the surgery. He was just phenomenal in every single way. And because it was genetic related, which I'll explain in a minute, my children, adult children, have been seeing Dr. Davidson for years. I know, unfortunately, he's going concierge, and I'm not sure they're going to continue. But A+ and A+ for them. but a couple of questions. And in my case, I never had high cholesterol. I never had high blood pressure, or any sim or anything like that. Kept my weight down. All those. I did everything right. However, genetically, my father died of a heart attack at 41. His father died at 54. And so at 63, I ended up with triple bypass. And my question is, so I really had and I had no symptoms. I had nothing. Do you see a lot do you know if that's common or, and the only difference now is my kids, adult children do go get checked annually for the same reason genetically. But I think Dr. Summers even said at the time you're the classical case of where your genetics took over, as compared to your lifestyle. How common is that? Because the other people I know that have gone through that, were generally way overweight or didn't take care of themselves, etc.
Yeah, that's a really good question. And I don't have exact numbers to tell you, but I think that one of the most predictable um, factors is what happens to your first few relatives. So I think that anytime I'm meeting a patient for the first time, I really want to ask, what did your dad have heart disease? Did your brother have heart disease? Did your siblings have heart disease? And I think that as more time progresses, we've identified more factors than just LDL. I focus today on LDL, but there's other things that we know that increases risk. And so one of those is LP little a, which I didn't even get into, and that's a whole nother category, but it's a type of cholesterol that runs in families that can be high that definitely increases risk. There's another entity that is coming out with more and more data, which is the whole inflammatory pathway, which we screen with high sensitivity CRP. And there was this group from Harvard that really showed that people with elevated high sensitivity CRP have independent risk factors for coronary disease. And so I anticipate that as our research and our science gets better, we're going to identify more and more of these things we don't even know of yet. And so I'm not sure if we just haven't figured out what is in your family. But I'm curious to see if you've ever had an Lp(a) or a high sensitivity CRP check before. I'm sure you've had with Dr. Davidson.
Yeah, I have to. The other thing is relating to, so in my case, I was 63 years old when I had this. So then I have triple bypass, still take care of myself and all that. I, I've heard mixed about I mean, I look at it and I think this is probably the wrong way, that it took 63 years for that to happen. And I do go every year for my regular physician exam, and I do go to a cardiologist every year who looks at me. But my question is, what's the likelihood, generally speaking, that I'm going to have to go through something like that again, assuming I've kept my lifestyles exactly the same as it was?
Yeah. I don't know if I have a good answer. I don't have an exact number or percent chance. I think that and it also depends on what modifications we've been able to do. If you started with high sensitivity CRP that was high and we reduced it to normal levels, I think your chances are very, much lower. So I don't know exactly your variables, but I will say that doing all of these things certainly does not hurt. And I think it's, very important to doing all the things that you said you can do, making sure your blood pressure is good, making sure your weight's controlled, making sure you're getting the amount of exercise in. But I don't know if I can have an exact number to say what the chances are of having another event. I want to try to make it as low as I possibly can with the tools I have. And that's, I think, my goal, and I'm sure that's what Dr. Davidson's goal as well.
Now, I know maybe you or Debbie may know that. Do you get a lot of patients that go through a second bypass somewhere down the pike? Is that, I don't know. Do you get a lot of that or not? I personally, I don't know anybody, but
I've seen a handful personally. I'm a third year fellow, so I've only been doing this for 3 years now. I'm still in training, but I've had a handful of patients who've had to have repeat secondary bypass surgeries, but I would say the vast majority do not.
But there are, Michael, a lot of patients that have had bypass surgery that then go on and have stents. because they have some narrowing or blockages that have gotten worse over time. They didn't necessarily need to have another heart surgery, but that it was a more minimally invasive intervention that could be done. But it all ties back to having that underlying coronary artery disease and probably an increase in the development of those plaques, which then kind of circles back to the whole having elevated cholesterol levels. So, I mean, the short answer is maybe, but certainly you're doing all the right things. You're following up with your cardiologist. You're taking the medications the way you should be. You're, watching your diet and your weight, and your exercise, and you're updating your family. I mean, that's a really important thing. My father had coronary disease. His mother had a heart attack. My dad never had any type of intervention, but he was on lowering medication, and so am I, and so, and I'm telling my kids. So it travels through the family. Certainly letting your family know and knowing your family history is really important too, to prevent having, I don't want to ever have a heart attack. So it's more prevention than anything.
Yeah, well, you start worrying. I mean, the logical thing is you start worrying. I never thought about it until I was in the hospital after my surgery. When Dr. Summers told me I was a classical case as far as genetics, and I start thinking, okay, wow, my son's almost the age that my father was when he died of a heart attack. Even though he's fit and all that, I guess if you have the genetics, you have the genetics. So, but yeah, okay, well, I really appreciate. Thanks. Good answers. Thanks for your help.
Yeah, really good questions. Any other questions we
My situation struck a chord with the gentleman's question with respect to genetics.
Yeah.
It seems like in his case, whatever he was doing, genetics trumped everything. That's terrible to say, but it's factual.
Mm-hmm. That's
My
true.
own father's case, he was one of 5 siblings. 2 died suddenly of heart attacks at age 62. This is already 40 years ago. Maybe that's even before statins came to the market. When did statins?
Well,
like late 80s, early
yeah,
90s?
very close to that.
So my father had statins. He never had a heart attack. He did have open heart surgery. I've had statins for probably 20 years, and I had surgery. I never had a heart attack. The other commonality with respect to his 5 siblings, 3 of them had heart attacks. All 3 of them were smokers. The 2 who did not have heart attacks were not smokers.
Well, you know what smoking does.
Pretty.
Besides it ruins your lungs, it narrows your blood vessels.
Mm-hmm.
So you're working with half the space to get blocked if you're a smoker, essentially, to then have a heart attack. So it's smoking is a really, really, really big risk factor for having a heart attack. Not the only one, but it's pretty much at the top of the list.
It's single-handedly the worst thing you can do for your health, like decision you can make for your health. So,
It's amazing how many people still smoke, though.
Yeah.
I mean,
yeah.
You could hit people
Amazing.
over the head with a hammer.
I know it. No.
But I wouldn't, necessarily get down about the genetic component. I would just make, more awareness about it with you and your family, because we do have really good medications. That's why screening is so important. We want to detect these high cholesterol levels at an early age. And every day we get more and more agents that help lower heart attack rates and whatnot. The data coming out for PCSK9 inhibitors, so impressive. GLP-1 agonists, so impressive. SGLT2 inhibitors, so impressive. So I would just, reinforce to your family members that this is what happened to my siblings, this is what happened to me. I care about you, so you should see a doctor.
And the other thing too is the testing now has become so specific.
Hello?
Um,
No.
I say it one more time. Oh, no, maybe not.
You understand that?
Not very easily, but when they repeat it twice, it's not a good thing. But I knew that there was coronary disease and higher cholesterol in my family, so I got my cholesterol checked every year. But it wasn't until a year ago that I did the Lp(a), which was for me, my LDL wasn't fabulous, but it was within a normal range, so I never got started on any medication. But it was until they did the more specific type of the testing that was pretty high in me, that I was started on a medication. So as the testing's gotten more specific and better, they're getting more and more people on the medications earlier to prevent events in the future. So again, 40 years ago when statins came out, you didn't get put on it unless your LDL was like 130, which is a ridiculous number right now.
When I started, I think they wanted to have the cholesterol level down to 160.
Yeah.
The total.
Right. Yeah. So the range is different. It's more specific now, and they're trying to get it more preventative. So, it's really, really, really important to know what your family history is. Parents, siblings, so on and so forth.
I actually take that back because when I started, the number was 200,
For total cholesterol.
Your total cholesterol.
and it's gotten down to 160. Now it's the top.
And Lp(a) is a talk in and of itself. It's another a lot of emerging data coming out of Lp(a). And what's hopeful about that is that there are medications in the pipeline that target Lp(a) themselves. They're not out to market yet, but they're in the pipeline.
I think there was a chat.
Oh.
Somebody have a question.
Is there anything yet for high Lp(a) levels? So not yet. Right now our strategy is that we know that Lp(a) is a risk to cancer, and so we use it as if someone has an elevated Lp(a), we're more aggressive with making sure their LDL is lower. But there are at least 2 medications that are in the very last stages of the trial, and I was told that they're supposed to come out very soon. Dr. Davidson told me that he thought that it's the FDA by the end of this year, but I think it's looking like early next year. But the point is that there are things in the pipeline coming.
Any other?
One thing it struck a chord in me. I'm an engineer, so definition of the problem is the first step. When you were talking about the way some of these tests are done, definition of what LDL really is hugely important. You can't solve the problem without knowing what the problem is.
Right.
And
Well, and they're coming up with a lot of, it used to be high density, low density, total triglycerides, and that was the big 4. And now they're even breaking it down into the minutia and looking at the specific components of those to see which one. Again, that's why the lipo(a) is big now, because we realize that it's a marker for increasing that risk, even if your LDL levels don't seem too out of the norms. And there's several the genetic testing, and I can't even remember all of them.
There is a lot.
Asking specifically to look at specific lipoproteins and the detail that goes into that is becoming more and more specific. and medications are targeting them specifically. You know, the goal is not to have a heart attack, to prevent the heart attack and the weakening of the heart and injury to the muscle. But sometimes that happens, and then the goal is to not have it happen again. So everybody's, you know, it's a little different depending on where you are with that. But we'll take care of you guys.
Yeah.
I gotcha.
Well, thank you.
Yes,
Yes.
yeah, I really-
Of course, we really like that.
yeah,